Hello, everyone, and welcome to the show.
Hi, everyone.
You're listening to Dentist's Coffee Time. Today, we are doing a really critical deep dive into something that is, I think, the absolute cornerstone of dental aesthetics, facial symmetry. Specifically, how we as professionals determine the true midline of the face and mouth.
That's right. Getting the midline right is probably one of the most frustrating and debated parts of any restorative, orthodontic, or cosmetic treatment. Today, we're going to be analyzing some really definitive research that essentially overturns decades of conventional wisdom about which landmarks, the nose, the philtrum, the glabella, are actually reliable.
Yeah, and our mission today is really clear. We want to provide you with a scientific, objective aesthetic framework and a verified set of guidelines that can serve as a blueprint for perfect aesthetic alignment. This isn't just about technique, it's about using hard data to calibrate our own visual judgment. So let's get into it.
Okay, so let's really break this down. Why does getting a precise midline matter so much, especially in what we do? I mean, aesthetics can be subjective, but the midline feels pretty objective.
It's because the midline is basically the gold standard of facial beauty. When we talk about aesthetics, we usually boil it down to three core elements: symmetry, normalcy, and youthfulness. And symmetry is always number one.
It's the foundation.
It's the absolute foundation.
Yeah.
And the midline is the starting point for all symmetry. A deviated midline, even by just a tiny margin, immediately becomes the most noticeable flaw in an entire smile design. Oh, I've seen that in the clinic. You place this beautifully crafted restoration. But if that midline is just a fraction of a millimeter off, the patient might not be able to articulate what's wrong. But they'll just say, something looks a little weird.
That's it, exactly. That's the human eye's incredible sensitivity to it. So when you're planning a full mouth rehab or an ortho case or even a single central incisor, if you don't have an accurate reference midline to start with, everything that follows, the occlusion, the alignment, even phonetics can be compromised. The precision of that midline is, it's really key to our success or failure.
So to really tackle this, we have to understand where the deviation is coming from in the first place.
Right. And to do that, we need to think about deviation in different layers. We generally look at the face in thirds, the upper, middle, and lower thirds.
And for us as dentists, it's really that lower third and the area around the mouth where we run into the most issues, isn't it?
It is. The first type we see a lot is what we call a functional deviation, or maybe more accurately, an occlusal deviation. And this one can be, it can be really deceptive.
What do you mean by that?
Okay, so imagine a patient. When they bite down hard into their maximum intercuspation, or IC position, their lower midline looks clearly off-center. But if you guide their jaw back into centric relation, or RC, that midline might suddenly line up perfectly.
So it's an occlusal interference causing it.
Exactly. A functional deviation is almost always caused by an unstable bite or some kind of premature contact. The mandible is essentially forced to shift sideways or forward to find a stable spot, and that shift makes the midline look deviated.
Okay, so the key there is that it's treatable within our scope.
For sure. If you can eliminate that interference, maybe through an occlusal adjustment or orthodontics, you give the jaw a chance to seat properly, and the midline deviation often just disappears. That's a dental problem with a dental solution.
But that's not always the case. What if the problem is in the bone itself?
Well, that's a whole different ballgame. That's a skeletal or mandibular deviation.
Yeah.
Here, the root cause isn't the bite, it's the actual structure of the jawbone itself. Maybe the condyles didn't develop symmetrically, or the chin point itself is just physically off to one side.
So even if their bite is perfectly functional, their midline will still look off just because the foundation, the mandible, is crooked.
Precisely. And these cases are often much more severe. For a significant skeletal issue, like a really deviated chin, if it's beyond what we can camouflage with dental compensation, we have to refer out.
Right, that's moving into the territory of plastic or reconstructive surgery.
Yeah, that often requires orthognathic surgery to physically reposition the bones. Our job as dentists is to be able to identify that it's a structural problem in the first place and know when it's outside the scope of what we can fix with just teeth.
Okay, so before we dive into the dental specifics, we should probably touch on a broader aesthetic concept that a lot of people might have heard of, the five-part law. I know it's huge in plastic surgery and art.
It is. The five-part law, or the rule of fifths, is one of those classic golden ratios of facial analysis. The idea is that the total width of the face, from the outer edge of one ear to the other, can be divided vertically into 5 equal sections.
And each of those sections should be about the width of one eye.
Pretty much. And one of the main rules that comes from this is that the width of the nose should fit perfectly into that central 1/5 section. Another little rule that's often tied to it is that the distance between the inner corners of the eyes should be roughly the same as the width of the mouth at the corners.
It all sounds very neat and tidy, like a universal formula. But for us, when we're in the clinic holding a wax rim or trying to position a central incisor,
Yeah.
how does a big picture rule like that actually create challenges for us?
The challenges are huge because these rules are mostly based on centuries of artistic observation and early surgical principles. They really lack rigorous scientific validation, especially when you try to apply them to the dynamic relationship between a smile and the dental midline.
Like the classic one we all learned, using the bisector of the interpupillary line.
Right. The interpupillary line is probably the most commonly used traditional reference because it seems so easy to find. But the real question is, does that line's midpoint actually line up with the true center of the face or the mouth? And then you have even more traditional methods like stretching a piece of floss from the glabella down to the chin to find the midline.
I remember learning those in dental school, but then you get a patient with even a slightly recessed or deviated chin, and the whole method just falls apart. It gives you a ballpark idea, maybe, but it lacks that scientific certainty you need to connect the dental midline to the facial midline.
And that's the core of the problem. These traditional methods created clinical uncertainty. When you're trying to align the maxillary central incisors to these unverified, often distant landmarks, the results are just not repeatable. And that leads to a lot of frustration, especially in complex aesthetic cases. This clinical dilemma is really what drove the search for objective, evidence-based research.
Yeah, and it's because of that long-standing clinical uncertainty that the dental literature was just crying out for a clear, verifiable set of guidelines. For years, the literature was full of contradictory advice, which meant clinicians often had to, just take a guess in complex restorative cases.
We've established how important the midline is, but why is the focus almost always on the maxillary midline, not the mandibular one?
It really comes down to aesthetic dominance. When someone smiles, it's the upper front teeth that are overwhelmingly visible and draw the most attention. So the coincidence of the maxillary midline with the facial midline is what really dictates the harmony and symmetry of the smile. So even if the lower midline is a little off due to function or a minor skeletal issue, as long as that upper midline is centered, the aesthetics can still be very acceptable.
Absolutely. The average person is far more sensitive to a deviation in the upper midline than the lower one. And this led to this long-running debate in academia. Should we be chasing global symmetry, where the dental midline aligns with the center of the entire face, or is local symmetry, just aligning it with the structures around the mouth, good enough?
What were the main viewpoints back then?
Well, on one hand, you had classic studies, like Miller's, which found that in about 70% of the natural population, the maxillary midline does coincide with the facial midline. That's a strong argument for always trying to achieve that in our treatments.
But there was a counter-argument, right?
Yes. Other experts argued that the human eye isn't as good at judging symmetry with distant landmarks, like the tip of the nose, as it is with proximal structures, like the lips. They believe that as long as the dental midline lines up with the center of the mouth and lips, the patient will be aesthetically happy.
And that's where clinicians were stuck. We had this long list of potential landmarks to choose from. The pupils, the nasion, the tip of the nose, the tip of the philtrum, the chin, even intraoral points like the incisive papilla. But with no scientific hierarchy, how do you choose?
This chaos really set the stage for objective research. We needed a study that could cut through all the noise and conflicting opinions and just use data to tell us, okay, here's what actually works. And that's the backdrop for the 2009 study by Bidra and his team.
Right, so Bidra's study had a very clear goal: to figure out which facial landmarks were most coincident with two specific key midlines.
And what were those two midlines? This is really important. The first was for global symmetry, the true midline of the face. The second was for local symmetry, the midline of the oral commissures, or the corners of the mouth. The goal was to create a ranking, a hierarchy, of which landmarks were best for aligning with each of those two midlines.
But to do that objectively, they first had to solve a fundamental problem. How do you even define the true midline of a face, which is dynamic and irregular in shape?
And that's where the most innovative concept of their study comes in, the aesthetic frame. They recognize that it's nearly impossible to define a single constant geometric center for the entire dynamic face. So they decided to find the center within a very specific, highly sensitive, and objectively measurable area.
It sounds like they created a sort of scientific picture frame for aesthetic analysis.
That's a perfect way to put it. Let's visualize how this frame was built. It's a very precise rectangle.
So how is the top border defined?
The superior border was a line connecting the exocanthions. Those are the outer corners of the eyes. That line became the key horizontal reference for the entire study. The side borders were then drawn down perpendicularly from that exocanthion line.
In the bottom border.
The inferior border ran parallel to the top one, right at the most inferior edge of the lower lip. This frame effectively captures all the key aesthetic elements we focus on when someone smiles.
But why be so specific about those borders? Why exclude the forehead and the chin, for instance?
That really speaks to the rigor of the study. They did that to eliminate what we call confounding variables. The forehead, for example, has high tissue variability. The chin point is often influenced by skeletal asymmetries and soft tissue thickness, making it very inconsistent. And you also have the soft tissues of the cheeks, like master hypertrophy, which can throw off the perception of overall facial width.
So by excluding these highly variable dynamic or distant tissues, they were ensuring that their facial midline was based on the most stable and aesthetically sensitive core structures.
Exactly. The midline within this aesthetic frame is determined by the area where our perception of symmetry is most acute. This makes their midline far more clinically objective and repeatable than a traditional midline based on the whole face. And that's really the foundation that allowed this study to successfully define an objective standard.
All right, let's get into how they actually gathered the data. For all the dentists listening, this is the part we really need to pay attention to because it proves these findings weren't just random observations, they were the result of incredibly strict criteria.
Yeah, the value of any evidence-based study is in the rigor of its methodology. The Bidra team knew that even a tiny photographic error or a slight head tilt from a patient could completely invalidate their midline measurements.
They started with 249 subjects, but ended up with only 87? That's a massive exclusion rate. They screened out 2/3 of the initial pool. Just that number alone tells you how strict the standards were.
Well, the goal was to eliminate any potential factor that could influence facial or dental symmetry. So right off the bat, they excluded anyone with a history of orthodontic treatment, facial trauma, or congenital conditions like a cleft lip. All of those would obviously affect the facial structure.
That makes sense. But what about the exclusion criteria for the teeth themselves?
This is a key point for dentists. Any subject with missing maxillary anterior teeth, any prosthetic restorations, or even spacing between the front teeth was excluded. They had to ensure they were measuring a completely natural, unmodified dental midline.
And on top of that, their requirements for head position and eye symmetry were also incredibly stringent.
This is probably the most critical part of measuring a midline. They required every subject to be photographed in a seated natural head position, or NHP. NHP is the position your head naturally holds when you're looking forward without any external cues, and it's been shown to be highly reproducible over time.
But here's the thing. How do you confirm in a photograph that the head is perfectly upright? I mean, in the clinic, it's almost impossible to get a patient to hold perfectly still.
And that's where the digital analysis comes in. Even if a patient had a slight tilt during the photo, the researchers corrected for it digitally. They took the line connecting the outer corners of the eyes, our frame's top border, and digitally rotated the image until that line was perfectly parallel with the true horizontal.
So even if the patient was slouched a bit in the chair, as long as that intercanthal line was leveled, the data was considered reliable.
And they were even stricter about ophthalmic symmetry. If the line connecting the inner corners of the eyes deviated from the horizontal by more than 1 degree, that subject was excluded. Yeah, because significant asymmetry in eye level can dramatically alter our perception of the facial midline. By using these incredibly tough standards, they made sure that the 87 samples that made it to the final analysis were captured under almost perfectly symmetrical and standardized conditions.
That level of rigor makes you wonder, when we're in the clinic dealing with patients who could never meet these lab-grade standards, how do we apply this data?
That's a great question. And the answer is, while we can't replicate lab conditions in the clinic, this study gives us a baseline. It tells us that for a landmark to be trustworthy, it has to prove itself reliable under the most stringent conditions. If a landmark is already off-center in the lab, it's only going to be more off-center in the clinic.
So which 4 landmarks did they actually test?
They analyzed the relationship of 4 key landmarks to the midlines. And to eliminate measurement errors, 3 of the soft tissue landmarks, the nation, the tip of the nose, and the tip of the philtrum, were actually marked directly on the subject's faces with a fine-tipped marker by a clinician.
So not just clicked on a screen later.
No, marked in person. The fourth landmark was the existing natural dental midline. This is important because marking them clinically, rather than digitally, reduces the secondary error that can come from photographic distortion.
Okay, let's talk about what I think is the most elegant part of this study. How they moved beyond simple linear measurements in millimeters to achieve true objectivity.
Right. Traditionally, we might say something like, the dental midline is deviated 2 millimeters from the tip of the nose. But as you said, that number is completely dependent on the magnification of the photo.
Yeah, if you take a close-up photo with your phone, a 2 millimeter deviation looks huge. But in a full-body shot, you might not even notice it. Linear distance just isn't a universal measure.
Exactly. So the researchers used what they called relative ratio values.
RFV and RCV. Let's really break down how these ratios work and why they solve the magnification problem.
Okay, so RFV stands for relative facial midline value. Its goal is to measure how close a landmark is to the midline of the aesthetic frame, which is our stand-in for the overall facial midline.
How is it calculated?
They measure the distance from the landmarks to one side of the aesthetic frame. Let's call that D1, and the distance from the landmark to the other side, D2. Then they calculated the ratio of the smaller distance to the larger distance.
So if a landmark is perfectly in the geometric center of the frame, D1 would equal D2.
Precisely. And if D1 equals D2, the ratio is 1.00, and that's the key. The closer the ratio is to 1.00, the more perfectly that landmark bisects the frame, which means the more reliable it is as a midline indicator. And because you're dividing one distance by another, the size or magnification of the photograph gets canceled out. It becomes an objective, proportional measurement.
That's brilliant. It makes the results universally applicable. And the same logic applies to RCV, the relative commissural midline value.
Exactly. RCV is all about local symmetry. It measures how close a landmark is to the commissural midline, which is the exact midpoint between the two corners of the mouth, or chilions.
So again, you're just checking to see if a landmark perfectly bisects the distance between the corners of the mouth.
That's it. If the dental midline is perfectly centered between the commissures, its RCV will be very close to 1.00. This design allowed them to independently evaluate how reliable each landmark was for both global facial and local oral symmetry.
And these measurements proved to be highly reliable, with ICC values between 0.85 and 0.96.
Yeah, the intra-class correlation coefficient, or ICC, is a statistical measure of consistency. Getting numbers that high proves that even with the complexities of marking soft tissue and making digital measurements, the data was extremely repeatable, which just adds another layer of confidence to the study's conclusions.
All right, so after all that meticulous filtering and measuring, the results are bound to challenge some long-held beliefs. For us in the clinic, this is the moment where we might need to recalibrate our aesthetic intuition.
Absolutely. The results are incredibly revealing and give us a very clear hierarchy of what to trust. Let's start with the pursuit of global symmetry. That is, which landmark came closest to the center of the entire aesthetic frame?
So we're looking for the landmark with an RFV value closest to a perfect 1.00. Traditionally, you might guess it would be the nation, since it's high up on the face and seems stable. But the results were, well, they were completely unexpected.
The results showed very clearly that the structures around our mouth are far more reliable than the distant landmarks we've traditionally relied upon.
And number one was?
Number one, the midline of the oral commissures. It had a mean RFV of 0.979.
That is a stunning finding. It means that if you want to find the center line of the entire facial aesthetic frame, the most accurate way to do it is not to look at the nose, but to find the midpoint of the mouth.
Exactly. It strongly implies that in nature, the human body tends to place the center of the mouth almost perfectly within that central rectangular zone defined by the eyes. This is our most stable, soft tissue reference point for finding the overall midline.
So where did the one we care about most as dentists, the natural dental midline, rank?
Number two, the natural dental midline with a mean RFV of 0.977. It's incredibly close to number one. This reinforces the idea that for most people, the dental midline is naturally in very close alignment with the facial midline.
And coming in third was another landmark we often use around the mouth, the tip of the philtrum, with a mean RFV of 0.974. So those three really form the top tier of references for locating the facial midline.
Yeah, all three of those are above 0.974, which shows their extremely high reliability. They are all proximal structures right in that core zone that has the biggest impact on aesthetic perception.
Okay, now let's look at the landmarks we've often trusted that turned out to be less reliable.
Number four, the nasion, or the root of the nose, with a mean RFV of 0.967. And in last place, number five, the tip of the nose. Its mean RFV was only 0.965, making it the most deviated and least accurate landmark of all.
Hold on, that feels like a clinical myth being busted right there. So many of us, when we don't have other tools, will instinctively use the nose as our initial visual guide. This data is telling us that relying on the tip of the nose to position a dental midline is starting from a point of error.
It is. This is the value of evidence-based science. While the nose is visually prominent, its soft tissue variability, its shape, and its structure make it geometrically unreliable. The tip of the nose is the landmark with the most deviation, and we really need to stop thinking of it as a dependable guide for the dental midline.
Okay, so let's shift focus to local symmetry. The question now is, which landmark aligns best with the commissural midline, the center of the mouth itself? This is especially important for local restorations or orthodontic design. We're looking at the RCV rankings now.
And when you look just at the local area, the results once again confirm the reliability of proximal structures.
Number 1, the natural dental midline, with a mean RCV of 0.9751.
And that is hugely important. It proves that the dental midline itself is the structure most closely aligned with the center of the mouth. It also provides indirect support for using the incisive papilla as an intraoral reference, because the papilla is typically located right between the central incisors, making it highly correlated with the natural dental midline.
And in a very, very close second place, the tip of the philtrum with a mean RCV of 0.9748. I mean, that's almost identical. The difference is negligible.
They are virtually equivalent for local symmetry. That makes them a powerful combination. Clinically, if you're having trouble pinpointing the dental midline on a photograph, the tip of the philtrum serves as an excellent confirmation point.
So how did the distant landmarks perform in this local analysis?
Third place was the tip of the nose, with an RCV of 0.9512. And in fourth place, the nasion, with an RCV of 0.9477.
So it's interesting. The tip of the nose slightly outperformed the nation when looking at the mouth midline specifically. But overall, they are still miles behind the dental midline and the philtrum in terms of reliability.
That's right. The data tells us one thing loud and clear. Whether you're measuring against the global facial midline or the local mouth midline, the nasion and the tip of the nose are consistently the least reliable choices. Their deviation from the center is significantly greater than that of the oral structures. These two distant landmarks should no longer be considered primary references in dental aesthetic planning.
Okay, the data has spoken pretty clearly. Now we have to translate these rigorous scientific findings into concrete actions in our day-to-day clinical practice. What's the real-world impact of this study on how we plan our cases?
The impact is decisive. It gives us an objective hierarchy, which lets us move away from judgments based on "I feel like" or "in my experience."
So we can now definitively say to our listeners that the most reliable big three aesthetic landmarks are what?
Without a doubt, whether you're dealing with a complex removable denture, a full mouth reconstruction, or anterior cosmetic veneers, your core reference landmarks should be: number 1, the midline of the oral commissures; number 2, the natural dental midline; and number 3, the tip of the philtrum.
This really confirms that we should be focusing our attention on those proximal structures. So for a prosthodontist fabricating a wax rim, what does this mean?
It changes the very first step of setting up teeth. You should no longer use the tip of the nose as a primary reference. You should first find the exact midpoint of the intercommissural line and use that as your working midline. Then you use the tip of the philtrum as a secondary confirmation. It's only when those 3 points, the proposed dental midline, the philtrum tip, and the commissural midline, are all aligned that you can be confident that your midline is properly oriented to the facial aesthetic frame.
And for orthodontists, if they see a deviated dental midline, their primary goal should be to align it with the philtrum and the commissural midline.
Yes. This study provides clear support for the importance of local aesthetics. Our goal should be to harmonize the teeth with the proximal soft tissue structures that have the greatest impact on visual perception. Even if orthodontics can't fully correct a minor skeletal asymmetry, if we align the maxillary midline with the center of the mouth and the philtrum, we will achieve the optimal aesthetic result.
So what about those distant landmarks that the data proved to be unreliable? The nasion and the tip of the nose, should we just completely discard them?
In the context of determining the midline, yes, they should be demoted. Their deviation values prove they are inadequate as either primary or even secondary references. We have to understand that while the nose is anatomically in the middle of the face, the variability of its soft tissue structure and the difficulty in marking it accurately make it the least precise choice for determining a dental aesthetic midline.
You mentioned a methodological point earlier. that it was inherently harder to clinically mark the soft tissue nasion and nose tip than it was to mark the philtrum or commissures.
That's true. The morphology of the nose is complex, and soft tissue thickness varies, which makes it hard to pinpoint a landmark accurately, even in a controlled lab setting. This probably contributes to their lower reliability scores, but it also proves that relying on them in the clinic will only introduce more error.
I think this study also gives us a powerful tool for patient communication. When a patient questions whether our design is aligned with their nose, we can now pull out the data and explain that we're basing the midline on the scientifically validated structures around the mouth, which have the biggest impact on aesthetics.
Communication is so important. At the end of the day, the final judge is visual perception. And what this research tells us is that the human eye is most sensitive to symmetry deviations in the immediate oral region. We now have an evidence-based framework to focus our attention on. The horizontal level of the exocanthion line, the vertical of the commissural midline, and the position of the philtrum tip. Those three form our new scientific aesthetic frame.
So to sum it up, many of the macro-level, unverified golden rules we've relied on in the past now have to give way to this more objective, proportional, and locally focused standard.
That's right. We now know that as long as we get the maxillary midline to align perfectly with the tip of the philtrum and the center of the mouth, we've done the most we can to ensure it coincides with the true aesthetic center of the face.
This deep dive has really taken our understanding of the facial midline to a whole new level. It completely reframes how we should think about visual symmetry. That our perception of symmetry is most powerful in the immediate area around the mouth, not across the entire face.
It really does. And the study tells us something else that's really important. The natural dental midline ranked second closest to the facial midline, with that high RFE of 0.977. This strongly suggests that most people by nature already possess a very high degree of innate symmetry. But at the same time, it also tells us that no one's ratio is a perfect 1.00. The human face is inherently subtly asymmetric.
Which leads us to a much deeper clinical and philosophical question. Since we know that the average person's face already has minor discrepancies, and most of that deviation is imperceptible,
Do we, as clinicians, always need to chase a theoretical to the micrometer perfect coincidence? Or should our treatment goal be set within a range of deviation that is aesthetically acceptable and visually imperceptible to the average patient, thereby balancing perfectionism with clinical reality and efficiency?
that's a fantastic, open-ended question about the balance between chasing perfection and accepting natural human variation. It's something every clinician dedicated to aesthetics should think about the next time they start planning a case. Thank you all for joining us for this deep dive today. Thanks for listening to Dentist Coffee Time. Bye-bye.